a busy program. We're all looking forward to it. I think we'll, those of us who do this every day will learn something, which is a good thing. So my name is Leslie Dock. I'm the chair and founder of Protect Our Care. It's good to see everybody. Thanks for joining us, including all the folks who are joining virtually. Thanks for taking and spending your morning with us. Protect Our Care was founded in the end of 2016 to try and stop the repeal of the Affordable Care Act. Those of us who had spent many years sustaining the Affordable Care Act just thought we had to give it one last try to keep it going. And thanks to people like Don and others, we all succeeded. And since then, we've been working hard to make healthcare more affordable, more equitable, and more accessible for everyone in America. The last few years have obviously been incredibly productive in moving healthcare forward at the federal level through the Inflation Reduction Act, the family plan, and we've seen that in the numbers as we see more, the highest number of people on the ACA that we've ever seen before. Of course, the same opponents are out there trying to take it all away, and we've seen Donald Trump double down on that, and the folks, the Republicans in Congress, very much following that agenda. Not only is all of this at risk in our politics and all of it at risk, but it's also at risk in the courts. So we've seen an onslaught of challenges, many of them ideological in nature, all of them extreme in many ways. I think people understand that farm is up to and trying to protect its business. You can't quite, if you understand who wakes up in the morning and decides that their prize in life is to take preventive services away from 150 million people. But here we are. And they haven't been vetted by a court system that now allows pathways to the Supreme Court in ways that we didn't have. We hope that everybody will find value in this session. As you know, we are joined by over a dozen legal experts looking at these cases, where they are today and where they're going. To end up probably at the Supreme Court finally. We'll hear from three panels, one on Braidwood v. Becerra, which is the effort to eliminate those preventative services. The second are the multiple cases that we have on trying to overturn the power of Medicare to negotiate for lower drug prices. Many of those cases have been adjudicated, so far positively on our side up to now, but there are more to come, and undoubtedly Former will be back as further milestones in the program deliver. We also want to be sure that we have time to hear questions from all of you, so we have time for questions at the end of each of these panels. So let's get going. Our kickoff speaker this morning, we're very honored to be joined by Former Solicitor General Don Verrilli, who has really been the person who single-handedly has done more to protect our health care in the course than anyone else. Most of my relationship with him has been on SCOTUS blog, but they've all had happy endings. So that's a pretty good track record. I've been in a lot of conference rooms staring at SCOTUS blog big on the screen, as if that was entertaining. And so we all thank God. He served as Solicitor General of the United States from June 2011 to June 2016. He's now a and is well recognized as one of the leading Supreme Court advocates in America, sitting next to Andy Pincus. So we've got at least a great twosome sitting here. He argued more than 50 cases at the Supreme Court when he was Solicitor General, and of course many other in his career. Any of us who've been involved in trying to protect the Affordable Care Act understand his contribution. For those who may not know, he basically saved the Affordable Care Act 3 times in front of the Supreme Court in 2012. We all remember NFIB versus Sebelius, where we almost lost the whole thing. We lost Medicaid expansion, but Don helped us save all the rest. Then in King versus Sebelius, where there's the question about the definition of the advanced premium tax credits and who can benefit from them, we won that as well. And in 2020, he's served as pro bono counsel for the House of Representatives on another case. Again, there would not be an Affordable Care Act today if it wasn't for his leadership. So it goes without saying that we are all grateful, and so it's with that gratitude and admiration that I welcome Don to this podium. Thank you. That was exaggerated.
It's our privilege to be here with you this morning. My work more important than work.
So 11 days from now will be the 14th anniversary of the day President Obama signed the Affordable Care Act into law. So 14 years in, here's what we know. First, the ACA has lifted up tens of millions of Americans by giving them access to health care that they could not otherwise afford. Second, organized forces on the right are still in Captain Ahab mode. They're obsessed with denying as much health care as they can to as many people as they can, particularly reproductive care. And third, the fight to keep the gains we've made and to extend them is far from over.
Has taught us some lessons over these 14 years, and I want to focus on two that
really hit home with me over that time.
the first one is, do not underestimate the determination and creativity of your adversaries, and don't underestimate the attractiveness of
And the second is that vigorous public engagement is absolutely vital. So now the first lesson, don't underestimate your opponent's determination or appeal. Looking back, I think it's pretty clear we made that mistake in litigating NFIB versus Sebelius. The ACA's opponents were fully committed to the project of creating a comprehensive and focused public narrative.
Constitutional federal overreach, that it was terrible policy, that it would take away your freedom, that it would intrude on important personal decisions, and that, not to mention that it would fund abortions. My sense of things at the time, and it's been solidified looking back over the years, is that liberals and progressives didn't take that critique seriously enough in real time. And the idea that the individual mandate of the ACA couldn't be justified as within Congress's Article I commerce power because it regulated inactivity or mandated that people participate in the market struck many on the left as borderline frivolous. The market for individual health coverage was obviously interstate commerce. The ACA regulated that market by forbidding insurance companies from discriminating based on pre-existing conditions, by requiring that most people purchase coverage, and by providing subsidies that made the coverage affordable. So, I looked at it as well. The market had a problem. The ACA tried to fix the problem. That's classic commerce regulation. At the very least, the requirement to purchase health insurance was necessary and proper.
Discriminating against people with pre-existing conditions work. So, it seemed to us that this was, an open and shut case. But if you looked at it the way the challengers did, focusing not on the problem Congress was trying to solve, but on the method Congress chose to try to solve it, they had a basis to say that the ACA went beyond anything the Supreme Court had previously authorized because it required people to purchase insurance. Now, fortunately, we had enough sense to make sure we had a strong backup argument in the tax power. And as I look back on it, I'm especially glad that we put as much effort into the tax power argument as we did. But I do feel like there was a lesson to be learned about taking arguments seriously because we didn't win on the commerce power argument, as you know. We only got 4 votes for that. So by the time King versus Burwell rolled around 3 years later, there was no way we were going to underestimate the potential force of the challengers' arguments. And we put everything we had into making sure that we took those arguments seriously and offered the very best counter that we could. And then, that was especially an especially important lesson for the third case, California v. Texas, that the Supreme Court decided in 2020. that challenge seemed to most people, including a lot of conservative commentators, to be silly, like just a silly challenge. It would have been very easy to not take it sufficiently seriously. But of course, the argument did prevail. That challenge did prevail in the Fifth Circuit. And you may remember that the Trump administration embraced the argument and challenged the Affordable Care Act as unconstitutional based on it. And so we took all of those arguments deadly seriously in our representation of the House in defending the law in front of the Supreme Court. And one particular thing that we did was we put a huge amount of energy into developing an argument that the challengers didn't have standing, because we thought that would be a really good off-ramp for the Supreme Court to leave the law intact, to reject this challenge, but not say anything on the merits about the law. And of course, that is what a majority of the court did. But, there is still a lesson there in that this argument that we all thought was borderline crazy, two justices agreed with in dissent. So it does kind of give you some sense of where things are in terms of the need to take these challenges seriously. So now the second lesson, which is really a variant of the first, I feel just as we didn't take the legal challenges seriously enough, we didn't take the importance of public messaging seriously enough, and especially the need to counteract their campaign around NFIB. And I think it was in part for the reasons I said before. We thought that the legal challenge really didn't have a lot of strength to it. But it was more complicated. I mean, if you all think back to 2012, 2011, the Affordable Care Act was not exactly popular back then. Its benefits were not being experienced by most people who now experience those benefits. Standing up to the law, to defend the law, meant you had to use some political capital, and not everybody was willing to do that. Of course, none of that was true on the other side. Day after day, Republican senators rose to give speeches denouncing the law as unconstitutional, as an assault on freedom, et cetera. The Heritage Foundation and other groups poured enormous resources into creating the impression that the law was illegitimate in every way, unconstitutional, unfair, ruinously expensive. You had a relentless assault from legal academics, leading conservative lawyers. I mean, if you think back, remember how many times you heard about being forced to eat broccoli back in 2012? Well, that was all just part of that organized effort. And it's not that we did nothing. Some of you were out there fighting the good fight back then, but we effectively got drowned out in the public square, I thought, in 2012. And I don't have any doubt that public campaign affected the way the Supreme Court viewed the case. I went back yesterday and looked at the oral argument transcript, and the word broccoli came up 6 times at oral argument, 6 times. So it gives you some sense of the way in which that whole thing worked, that whole campaign worked. And it was really an example of what Yale law professor Jack Balkin described as an argument going from off the wall to on the wall, from an argument not being taken seriously to being taken seriously because of that relentless campaign. So again, when we got to King versus Burwell, we had learned that lesson, and because of people like Andy and Leslie and others in this room, we organized an enormous public campaign to get the message out that everything that the challengers were saying about the legal arguments being made in King v. Burwell was wrong, that there was no way in the world that Congress would ever have structured a law so that if states chose not to set up an exchange themselves for the purchase of individual health insurance, that they would lose access to the subsidies that made the system work. That is not, in fact, what happened in the legislative process, and it would have been insane for Congress to enact such a law. And there was a really important part of that campaign was making clear what would happen in the event that the challengers won, that the individual health insurance markets in states that hadn't set up their own exchanges, which was most states, would collapse, and that millions of people would lose their health coverage entirely, and millions more would see their premiums spike up. And there was no doubt that that's what would happen. So by the time King v. Burwell got in front of the justices, the atmosphere was completely different, and it I think made a really big difference in the way, as SG, I was able to argue that case, and in the way the justices viewed it and ultimately decided it. I think for one thing, it really boxed the challengers in. They had to make a judgment about. They had two very unpalatable options as a result of this messaging that we did so effectively. And the first option was to say, well, no, Congress actually did design a crazy statute that would self-destruct if states didn't set up their own exchanges. Or, no, Congress didn't mean to do that, but the statute was drafted in a sloppy way, so you need to blow the whole thing up. Those are really the two options that the other side had to them, and there was no way to make their position seem reasonable. And I really do attribute that to the extraordinarily intense and focused and creative public messaging campaign that preceded the 6 months leading up to oral argument in the case. It was just absolutely vital, I think. And then again, it got to California v. Texas in 2020, and once again, people knew enough to take it seriously and to engage in that same kind of messaging campaign in a way that I think really did help create an atmosphere by the time that case was argued in front of the Supreme Court that this was an argument that just didn't have any teeth to it and shouldn't be taken seriously. So I do think those lessons are even more important now because, of course, the court that I was dealing with as SG was quite a conservative court, but the court's moved a great deal even since then. And arguments of the kind that the challengers are bringing and the matters that you're going to be talking about today are going to have appeal to some of the justices, maybe a majority of the justices. So it's going to be vitally important, I think, to really push to take those arguments seriously, figure out the most powerful legal responses, and also to engage in the same kind of effort to help the public understand just how misconceived the other side's approach to this statute and how it works is, and just how horrible the consequences will be for millions of Americans if they succeed in their endeavors. Anyway, so that's my advice for you, and I'm very glad to be able to be part of this, and wish you all the very best in this work. Thank you.
That was put on the court on purpose so that we be able to vote on that case. So there's a lot of drama there. Yeah, we got it up. Yeah, we did. Let me just quickly, I'm just going to introduce the moderator, my colleague, Joy Cheney, who's going to moderate this panel on the Braywood v. Becerra case. Joy is a senior advisor for policy and health equity at Protect Our Care. We're extremely happy to have her on our team. She's got experience all throughout the issues and throughout the government. She was the Senior Vice President of Policy at the National Urban League. She was Chief of Staff to Senator Gillibrand. She worked at Planned Parenthood and also at the Democratic National Committee and in the Obama administration, and she's a graduate of Howard University and Harvard Law School. And with that, I'll turn it over to Joy.
Thank you so much, Leslie. Can everyone hear me? All right. It's been a privilege to work at Protect Our Care thus far, and I am very excited about today's panel. Although when I look at my intro remarks, I feel like I look a little bit like Senator Katie Britt. Because it's pre-learning. So in March 2023, Texas District Court Judge in the Northern District of Texas, I should say, Rhoda O'Connor struck down a provision of the ACA that requires insurers to cover life-saving preventative services at no out-of-pocket expense for patients. A protection relied on, pardon me, and many of you, and 150 million Americans. It guarantees coverage for cancer and heart disease screenings, prenatal care, vaccines, pre-exposure to HIV treatments, and beyond. Overturning has and employers who could once again charge for preventative services, increasing patient costs and creating major obstacles to care. The ACA's elimination of out-of-pocket services has transformed, really, how preventative care is delivered. Reduced disparities in care, cut consumer costs, improved health outcomes, and saved countless lives through early detection. I think sometimes we are victims of our own success. We've done so well, some people don't even remember what it was like in the bad old days. Moreover, is right now preventative care something for wealthy, disproportionately white people. It's available to all of us. Let's get real, right? Well, everyone, as it makes its work, we're finding out just who would put that at risk. There are people who are interested in those arguments, as Mr. Verrilli said. So last week, a three-judge panel in the Fifth Circuit, our favorite circuit, right? Heard oral arguments in the case. The plaintiffs argued that the district court's ruling did not go far enough, indeed, to overturn the requirement that insurance cover preventative services, while the lower court, one, overturned a narrow set of services recommended by the U.S. Preventative Services Task Force, that will be called the task force hereafter. After the passage of the ACA, it too blocked requirement coverage of the task force's future recommendations, great. And three, allowed employers to refuse coverage for certain preventative services on religious grounds. The plaintiff now wants the appeals court to go a step further and overturn the ACA's guaranteed free coverage of vaccines recommended by the Advisory Committee on Immunization Practices and Services, wonderful, recommended by the Women's Preventative Services Initiative, like cancer screenings, prenatal care, and contraception. Now, notwithstanding my jokes earlier, I don't like to attack judges, but we can't help but observe that two of the three Fifth Circuit judges on the panel, Don Verrilli and Corey Wilson, are Trump appointees, with long records of extreme rulings based on radical legal theories that aren't radical enough for some. These judges could strike down coverage for essential preventative services at any time, removing the current stay of the lower court's rulings and blocking free preventative services, putting them on the chopping block for more than, like I said, 150 million Americans covered through private health insurance. This panel, we have something to look forward to, is expected to issue a ruling within the next few months, and we know all of us on this panel, the good panel, will be looking at that. Hundreds of healthcare professional organizations, many of whom are represented here, providers and public health experts in 23 states and the District of Columbia, have filed amicus briefs, in this case in defense of maintaining the ACA's requirement to cover preventive services without cost sharing. All of our panelists today, as I said, have done so and filed amicus briefs in Braidwood v. Becerra. And so I'm fortunate enough to be sitting with a very senior one. This is an august panel indeed. Andy Pincus is a partner at the firm of Mayor Brown in Washington, D.C. He specializes in briefing and arguing cases in the Supreme Court of the United States and in federal and state appellate courts, as well as developing legal arguments in trial courts. He has argued 30 cases. Really? All right. Before the Supreme Court and filed briefs in more than 100 cases in the court. He is a graduate of the Yale College, we won't hold that against you, and Columbia Law School. Mary Reveles. And Mary, if I botched your last name, you'll correct me, won't you? You're right. All right, good. is Managing Counsel and Legal Advocacy Director at the American Cancer Society Cancer Action Network, and as a cancer survivor, yay, yay. She supervises all of the organization's advocacy in the judiciary, including leading amicus efforts by patient groups, beginning with the National Federation of Independent Businesses versus Sebelius, which was the original case upholding the Affordable Care Act in the United States Supreme Court. She continues to this day, representing 16 patient groups in the Braidwood litigation, and she is a graduate of Wellesley College and the University of Virginia. Now, coming up, we have another University of Virginia graduate and Columbia Law School, my friend, Gretchen Buchschultz. She is the Vice President for Reproductive Rights and Health at the National Women's Law Center. She oversees their advocacy, policy, litigation, and education strategies to promote reproductive rights and access to comprehensive, affordable health care, including abortion and birth control. She is my colleague in gender justice. I do some work with National Women's Law Center. I'm glad to be on with you. Then we have Dr. George Benjamin. He is the executive director of the American Public Health Association, leading the association's push to make America the healthiest nation. We got a long way to go, but we're getting there. From his firsthand experience as a physician, he knows what happens when preventative care is available and when the healthy choice is not an easy choice. He is a graduate of the Illinois Institute of Technology and the University of Illinois College of Medicine, like my husband. I am so glad to be on with all of you. Let us get started. Does anyone want to say anything before we begin? Let's get into it. All right, well, actually, I was going to buy some time while I turn to the you all didn't help me out on that. Sorry about that. So, Andy, you're my first question. And I hope all of you all will take some time to figure out what questions you ask, because we will have a little moment for that at the end. All right. So, Andy, as we talked about the case, and it was scary, but just remind us, for the audience, for those who are less familiar with this, because I think this case may be less familiar than some of the other ones that we're hearing. One that hasn't made it to the court yet, the Supreme Court yet. Why should Americans across the country be concerned about this case? I mean, I gave a little primer, but is there anything else you'd want to say about what happened in the district court? And then just walk us through some of the key arguments that are being made on both sides.
Sure. So first of all, great to be here with all of these great colleagues, and thanks to Protect Our Care for organizing this. As Don said, it's just as important when you're litigating a case inside the court. You want to make the best legal arguments, but you also want Americans to know what's at stake.
Yeah.
And so I think that's what one of our goals here. So as you said, the ACA, one of its many landmark changes was to say we're not going to make key preventive services that save lives, prevent disease, make people healthier. We're not going to let insurance companies decide which of those are going to be available, and also decide how much they're going to make people pay in copays to be able to access those services.
Right.
The ACA said we're going to define a category of critical services that insurers have to make available. They have to cover them, and they have to cover them cost-free. And I think what's critical about the ACA, I think when some people hear about this case, they say, well, ACA, that must be a requirement that just applies to plans that you buy on the marketplaces. No, it applies to virtually all insurance. That's why what's at stake here is not just the ACA marketplaces, it's coverage for 150 million Americans. So a much, much broader group of people. The statute, just to get a little granular, divides the categories of covered services into 4 parts. There's general services, which are identified by the task force that you mentioned, not even we're calling it the task force.
Yeah, we're calling it the task force.
Which is dozens and dozens of preventative services, and new ones are added every year as medicine makes advances. Medicine doesn't stand still. So what was a critical preventative service in 2011, when Congress passed the ACA, there are many more that have been added because they provide critical coverage. Immunizations, critical vaccine, women's health, and children's health. So 4 categories. So just to identify in general terms what's at stake: screenings for lung cancer, colorectal cancer, and other diseases. statins. A lot of Americans take statins to prevent heart disease. Have to be provided cost-free by the insurers. Pre-exposure prophylaxis, PrEP, critical to preventing AIDS. Vaccines for flu, shingles. I just took my second shingles shot on Friday. Pneumonia. Screening newborns for more than 70 different diseases and conditions after they're born. And contraception coverage, just to name a few critical things. So the plaintiffs here are 2 small companies and 4 individuals. And they don't just say, we don't want to have to pay insurers to cover these things cost-free. They say, we want a nationwide injunction that applies not just to us, but that would invalidate this requirement for all Americans.
Visionaries, right?
And, I think their supporters in the court, the state of Texas filed an amicus brief in their support, and a conservative think tank. The government on the other side, just to give you who the friends are, supported by the AMA, the American Public Health Association. I was honored enough to represent Dr. Benjamin's group, some other groups, and dozens and dozens of public health professionals. The National Women's Law Center filed a brief. The Cancer Society, as you heard, on behalf of many, many organizations that represent consumers who are subject to critical diseases, and a large number of consumer representatives. So there are 2 basic legal claims that the other side is advancing. One is that the groups designated by Congress to identify these services are not appointed in the way the Constitution requires, and therefore their decisions have to be invalidated. And second, Congress didn't provide sufficient guidance regarding the standard those groups should apply in deciding what preventative services should be in the mandatory coverage category. As you heard, the district court agreed with the opponents only with respect to the task force category. The district judge rejected the challengers' arguments for immunizations, women's health, children's health categories. But the district court did agree to award nationwide relief. The government immediately appealed, saying, we'll leave in place relief for these people, but you have to put a stay on relief as to the rest of the country. Their services are too important. There was some jousting, and eventually, sort of surprisingly, the challengers agreed to put on ice the order as it applied to everyone other than these specific plaintiffs. Before the Court of Appeals, the government is obviously trying to reverse the decision about the task force. It's also trying to reverse the decision that if it loses, it should apply nationwide. But the opponents are asking the Court of Appeals to invalidate the other 3 categories as well. One last point. You may remember first hearing about this case, about PrEP, and about the Religious Freedom Restoration Act challenge to the requirement to provide PrEP that Joy mentioned. That issue has sort of fallen out of the case. That ruling was limited to one of the plaintiffs, and so I think the government decided not to appeal that ruling because it had such a limited effect, and they're therefore focusing on these broad questions about the availability of preventive services.
That's super helpful. That's a lot, but it's very helpful. So, Dr. Benjamin, the American Public Health Association fought hard, as Andy just said, to include first dollar coverage of preventative services in the ACA Act. And so, ACA, can you describe for us how this requirement has improved the health of Americans? A little bit about what we're talking about.
Imagine you're 49 years of age, you've got a family, you're in the prime of your life, and you suddenly have a stroke because you have not been identified early with uncontrolled hypertension. Every one of us has probably had our blood pressure checked. It is a benign, simple, inexpensive test to do, but it's a screening test. It's been the evidence basis for that screening test has been well documented. and we understand the parameters of that test. But, you know, if you want to go get your blood pressure checked by a professional, quite often you have to pay to get that done. You can certainly go to your local grocery store, or you can go to a health fair in the community, but to get into the clinical system actually requires, in most cases, a copay prior to the ACA. I remember being in the emergency department with an older lady came in with chest pain. Her record said that she had hypertension and diabetes, and so our biggest concern was that she was having a heart attack. Until she was just rolled for her electrocardiogram, and the ulcerating mass on her chest, which was causing her chest pain, became very clear to us. Also very clear that catching breast cancer early can be life-saving. I know one of my colleagues is going to talk about that. I won't go into that, but just to point that out. Imagine being a parent and getting the phone call that your child has just died from meningococcal meningitis. We have a vaccine from meningococcal meningitis, a young person in the prime of life. I remember being the health officer in Maryland and having a lady, we had actually set up a screening program early on, and she had been seen in about 4 hospital emergency departments for rectal bleeding, and was consistently told that this was probably hemorrhoidal bleeding. Eventually, we were able to get her into one of our screening programs, and she had colorectal cancer. The good news was it was easily treated, and she survived that cancer. And then finally, lead is an extraordinary toxin, and yet we know that many of our children are exposed to lead in our drinking water. We have screening programs for lead. The real challenge with that, of course, is that children who are lead exposed do very poorly in school, so they don't learn very well. They have trouble with impulse control, so there's a higher incidence of those kids in the juvenile justice system. And my point for saying this is to try to put a real face on why this matters. We know that prior to the ACA, the problem the ACA wanted to fix was the underutilization of preventive health services. We also know that a first dollar coverage for those preventive health services is an extraordinary barrier. If you are low income in particular, $1 to $5 of cost sharing may mean you won't get screened at all because you're not going to go. Because it quite often is the amount of money you actually need to get to work, or to have lunch, or for your kids to have lunch. So people put off these screenings because there's a cost. And by the way, even well-to-do adults do the same thing for a variety of reasons. We also know that should this go away, there's a lot of evidence that both by experience and by survey that both the insurance companies and employers who are doing employer-based coverage will reimpose cost sharing. We also know that when the ACA went into effect, there was a dramatic increase in people utilizing preventive health services. And if COVID didn't teach us anything, the minute we made it free, we had extraordinary coverage for testing, for screening tests, for COVID. And the minute we reimposed the old system, utilization went dramatically down. So we have a real-world experience about what happens here. I'll stop.
Dr. Benjamin, let me just ask you a follow-up. One, I hope we'll talk about the disproportionate impact on communities of color, but if you're a physician and you're trying to decide what preventative screening someone's going to get, does that play a role here when you know the patient may not have the money to cover it? Inadvertently, not intentionally.
Yeah, well, obviously, sometimes you have to make decisions about patients. So you have someone who is unable to afford a particular test. You often have to temporize. You sometimes have to do maybe suboptimal screening. So, for example, a person comes in and you do the rectal exam, but you don't send them out for the blood test for their prostate because they can't afford it. But you do the clinical exam portion, and you might order it, but they're never going to do it. Or the same thing when we do colorectal screenings, and again, the person. If you do again the rectal exam portion of it, but they cannot get the full screening that you would like them to have, the full colonoscopy, because they cannot afford their component of the price. So you put it off and you put it off until you find a way to get it done. I think the other thing that's important, which I think speaks to this case, is that when Congress passed the Affordable Care Act, they were very careful to require these preventive services to be evidence-based. So they identify the entity and various entities to do these these screenings and decide on who would decide the evidence base and set up a process so that they would be approved through a structured system to make sure that less valuable tests were not done.
That's very helpful. And Mary, I'm going to go to you next. I mean, we know that for all the reasons that Dr. Benjamin just outlined, American Cancer Society is taking this very seriously. Can you talk about what's the disproportionate impact on cancer
Sure.
patients?
Well, I'm gonna reemphasize some of the themes that he said and add a little bit, if that's okay. Many lives are at stake in this case. Having access to no-cost preventive care really matters. Detecting cancer early improves the likelihood of successful treatment. It's less expensive to treat stage 1 cancer than it is to treat stage 4.
Yes.
And you are a lot more likely to save the person. So our organization feels so strongly about this case. I've actually seen the impact on the people who really understand what this is about. Their frenzy about this case is actually more than any other that I've probably seen, except maybe some of the Affordable Care Act challenges. Anyway, it can also prevent disease from happening altogether. For example, finding and removing polyps during a routine colonoscopy can prevent some forms of colorectal cancer from developing at all. So these screening tests are critically important. Research for over a decade has shown time and time again that even relatively small levels of cost sharing in the range of $1 to $5 are associated with reduced use of care. And Dr. Benjamin mentioned that there were many studies over the course of about 17 years that said this over and over again, which is why the public health groups are taking this so seriously. And just last month, actually, ACSK and my organization published a survey of cancer survivors showing that over half of them put no-cost preventive care as a top priority. It also showed that more than 40% of cancer patients and survivors surveyed report that the cost of their cancer care has impacted their ability to afford purchasing food. So, I mean, people are making the trade-offs. Over 40%, I'm just going to say that again, said that the impact of their cancer care affected their ability to purchase food. So, I mean, these are, if you have the choice between purchasing food, as Dr. Benjamin said, and getting a preventive service, it's very hard to make that choice.
And we know food is medicine. So.
Right, yeah. This negative impact is not born equally in our society. As Joy mentioned, people most likely to have experienced these problems are those with annual household income under $35,000, patients and survivors who are Latino, Black, enrolled in Medicaid, have lower educational attainment, LGBTQ+, and residents of U.S. territories. The striking health disparities we suffer in the U.S. will almost certainly be exacerbated if the plaintiffs win this case, because populations with existing disparities are the ones least likely to be able to afford the preventive care we all so desperately need. The case ignores good science. Again, as Dr. Benjamin said, the Affordable Care Act was written to account for the fact that medical treatment should evolve as we learn more over time about what works. And the scientific experts who sit on the task force and ACIP and HRSA are really devoted to understanding the latest evidence and translating it into effective practice. Some screenings, like lung cancer screening, weren't recommended at all when the Affordable Care Act was passed. And now we know that lung cancer screening can save a lot of people. So for the fact that essentially, I think there was an allusion to the fact that the judgment that the trial court made essentially invalidated all the recommendations since the Affordable Care Act passed. It's ignoring, 14 years of really important science that's evolved. And I remember I was describing this case to, some people, at the American Cancer Society, and one of our doctors said, "My God, this makes no clinical sense." And I was like, "Yep, that's Judge O'Connor." But anyway, I think that pretty much covers it. But we need to keep the services people can get in line with what the science tells us they need.
If you want to heal people, it makes no sense. If you have another strategy, who knows? Gretchen, so this doesn't have, this particular case doesn't have the same impact on women's preventative services and reproductive care, but it does threaten it, right? Can you just expound on that a little more, maybe explaining why, and then just in the broader context of the assault on women's health care? I'd love to know a little more about that. What impact would this have?
Yeah, well, thank you so much, Joy, and thanks to Protect Our Care for pulling us together for this really important conversation. So I want to underscore what you said, which is that right now the women's preventive services coverage is not blocked, it's not clearly at issue, but it is, and it's no mistake that women's health is threatened by this case. And I just want to do a little caveat, which is I'm using the term women because we're talking about the women's preventive services. That's how the ACA framed it. But those benefits are available regardless of gender identity or sex assigned at birth. So it actually is a much broader constituency who benefits and whose health is threatened by this case. So this case poses a huge threat to women's health and by extension their financial security, their equality in this country. And that's for two reasons. One, as Andy mentioned, it's still on the table, right? The challenges are still challenging all the preventive services, including the women's preventive services provision. So they brought that to the Fifth Circuit. They want to get rid of no-cost coverage of contraception and well woman visits and breastfeeding supports and supplies and all of the screenings that were specifically designed to remedy the historical problem of women not getting the coverage and care that they need. And then the other reason is that the task force recommendations, which are directly at issue and have been blocked but paused on ice, as you said, women benefit from those too, right? It's not just the women's preventive services that benefit women, it's all the task force recommendations. So we're talking about screenings for things like substance abuse disorder and depression and preeclampsia. These are all things that benefit women greatly. And so even just the task force recommendations pose a huge threat to women.
Women are people too?
That's right, women are people too, right? And have disparities in the kinds of services and the kinds of outcomes they see. And I think it's also just helpful to remember that a specific focus of the Affordable Care Act was remedying that historical discrimination of the lack of coverage of women's services in particular and the cost barrier that we know prevented women from getting those kinds of services. And you've already heard about cost being a barrier, even as low as $1. That's especially true for women. Women generally earn less than men. They are more likely to have higher poverty rates, and so those cost concerns really can be a barrier to people who are women getting the services that they need. And so the ACA set out to fix that exact issue, to make sure that the services were covered and that cost wasn't a barrier. And it has worked. There's reams of data. I could just kind of run through data. I could take up the whole panel of all the data that shows that, for example, there's more increased use and adherence to contraception. There are better screenings, depression screenings, that have led to better mental health outcomes. So we are fixing these problems, and we also know that the use of preventive services has increased in particular among women of color. And so it started to narrow some of the racial disparities that we had seen in outcomes for women in particular. And so the ACA, you talked about gender justice, it's a gender justice issue, it's also a racial justice issue.
That's right.
And so this Fifth Circuit decision has the potential to send us back in new ways that are going to be harmful to this country, which would be bad at any moment, but are especially devastating now in the midst of the chaos and the devastation of the Supreme Court's decision to take away the constitutional right to abortion and the ongoing crisis in maternal health. And so people need access to contraception to plan and space their pregnancies. They need access if they're either forced to be pregnant or if they choose to be pregnant, they need access to the kinds of preventive screenings that can help ensure better pregnancy outcomes. So there's a lot at stake. It is very dire, and I just, women's health is at risk, whether it's limited to the task force recommendations or whether these challengers are successful in their attempt to get to all the women's preventive services.
And let's be clear, today is Equal Pay Day, underscoring that women do not always have the same money that men do to cover these services. Andy, I'm going to go back to you. So, okay, we're going to get a little wonkier, like a law school class. what is this appointments and vesting clauses of the Constitution and the non-delegation doctrine? I mean, just for good measure, we know they're going to say it. We need to understand what Braidwood is talking about. What are the merits, if you will, of those arguments?
Yeah, so I'm going to get a little legal, but hopefully not too legal. So what the district court said is that the expert body, the task force, that makes these recommendations qualify as something that the Constitution calls officers of the United States.
Okay.
Sort of people who exercise significant authority. The Constitution says officers of the United States have to be appointed either by the president or by the head of a department. These task force members weren't, so the district judge said that means their recommendations go out the window.
Okay.
Now, what happened is, while this case was underway, Secretary Becerra formally ratified all of the recommendations since 2011. So the government says, doesn't that check the box? He's clearly a properly qualified officer of the United States. The court said, no, that's ineffective because there's a provision of the statute that says recommendations should be independent and, to the extent practicable, not subject to political pressure. The government says, to the extent practicable, if the choice is having recommendations with the secretary involved or no recommendations, clearly Congress meant the secretary can get involved if that's needed to give these recommendations the force of law. But that's the fight. And the government also says, by the way, on an ongoing basis, the secretary has the power to appoint members of the task force, and that's what he's going to do. The second issue is this non-delegation. People may have heard about this non-delegation doctrine. Has Congress...
They heard about it here, they didn't hear about it before.
Yeah. Simple words, did Congress give enough guidance on the test for deciding what's in and what's out on preventive services? The statute talks about evidence-based, as Dr. Benjamin said. That's a clear signal. But there's an even clearer signal, because the task force, ACIP, the group that addresses vaccines, and the group that decided children's health preventive services, all were in existence when Congress passed the ACA. Congress designated them. So it knew how they worked. It incorporated those standards by designating them, and it said that the women's health, which was new, should be done in the same manner as the children's health that was underway. So Congress clearly just said, we know what's happening, it works, use that process. But that's an issue. District Court rejected that challenge, but that's another issue that's back before the Fifth Circuit, in addition to this issue that has arisen in a lot of cases about when plaintiffs challenge government action, do they only entitled to relief for themselves, or do they get to decide what happens to the whole rest of the country? That's an ongoing issue. Maybe it'll be surprising to some. Justices Thomas and Gorsuch have said no. Cases are about plaintiffs. They get relief for themselves. Some other justices seem to disagree. That's an issue that the Supreme Court hadn't decided, but it's obviously a big issue in this case. If the relief is limited to these two little companies and 4 individuals, that's a lot different than 150 million Americans.
Yeah, very much so. We are going to open up for questions for the audience. I have a few that I can ask. Yeah. Anyone got any? Oh, yes. We don't have to have a mic. You can just say your question from your seat.
Oh, yeah. Hi, my name is Lisa. I'm from United States Don Verrilli. We've
Hi.
also been really active in supporting the work and kind of educating around what impact will be with the services. But obviously, I think we're on the opinion that Congress shouldn't do anything at this moment. We're wondering what you all are thinking there, and if you see a role for Congress down the line, and what you think how the magic 8 ball kind of plays out on this.
And that was on my list. That's good, girl.
I would say absolutely agree with you. At this point, we think the government has very strong legal arguments to defend these provisions, and we don't want to undercut those by essentially encouraging legislation that would sort of muck around or tell the Supreme Court that it doesn't have to take this case, or, do you know what I mean? So, I mean, our position is, at this point, we do not want legislation at the federal level that would undercut the legal arguments of the government.
Any other questions? All right, so Gretchen, I just want to go back to you for a second. You started to talk about some of the broader implications for women, for others, and really others can answer this as well. this case will, I mean, there's a long list of services that could be hindered, right? And we would lose, cost share, or no cost for it. What are the other implications for if this provision falls? Are there any unintended consequences, much like Dobbs led to other things? Is there anything else we ought to be thinking about and fearful of?
Well, there's so much to be fearful
So much, I know.
I mean, I'm going to take it a little bit of a step up, I think,
Yeah.
because I think and this is kind of building on what Mr. Verrilli said, like, there are bigger things happening here. This case is part of a bigger effort in this country to take care away, and not just take care away, but to really drive a wedge and use religion as a sword, use these baseless claims as a sword to undercut our long-standing laws and our kind of principles that we have that govern this country, right? So, bringing cases, cherry-picking these judges, Judge O'Connor in this case, as you hear about in the panel later today, Judge Kaczmarek, these are two Texas District Court judges who are willing to take these kind of what seems frivolous, what seems baseless, take these cases and issue these drastic sweeping injunctions for the nation that get rid of longstanding protections that people have had, right? And so this is a theme throughout, is that there is an effort to find these judges, to use these judges to then take these claims up, and because there are so many Trump-appointed judges and judges who have very conservative views, they are willing to entertain these claims in ways that we never thought should have been possible. We thought this case should never have been in court. It should have been laughed out of court. The same with the FDA case you'll hear about later. But these judges are taking them seriously, and so we have to take them seriously. And, the plaintiffs who are going to these judges, the reason they're picking them is because they don't want these protections. They want to take this care away from people. They are willing to undermine these laws. They don't believe in the rule of law, right? The person representing Braidwood is Jonathan Mitchell. Jonathan Mitchell is also the person who created Texas SB 8, the law in Texas that created this vigilante system for people to sue anybody for helping or providing an abortion. And so it is a strategy, it is purposeful, it is a desire to undermine our laws, and it's not just care. Braidwood and Jonathan Mitchell also are bringing a case in the Fifth Circuit where they're trying to get Braidwood out of complying with non-discrimination laws that are fundamental to this country, because they have a particular view about how people should live their lives. And so that is what I am worried about in terms of the implications. There are implications for care, but there are broader implications for our rule of law and our society and congressional authority and the regulatory state, how all of these things function. There's a desire to upend that completely.
Right, and it undermines democracy. This is clearly a choice that we had.
Can I just picking up on the congressional authority point, because I think it's
And this is your
important.
wrap-up, too.
This is my wrap-up, okay. Just picking up on that point, this is if you think about King v. Burwell and California against Texas, they were both efforts to sort of say there's this little glitch in the ACA, and therefore either the whole statute is blown up or it sort of makes the statute not work. And this is an effort, again, to find something that can then be used to take away this fundamental, critical right that's so important for protecting people's health care.
That's right, that's right. Dr. Benjamin, I'm giving you fair warning. I'm going to end with you. Mary. Anything needs to say, well, no, we're going to Mary next.
Okay.
Then we're going to end with you. Mary, anything else as you wrap up? What are you thinking about it? What do you think is going to happen? Can I ask that? Is that wrong?
Well, I'm hoping that more wisdom prevails, right?
Yeah.
I mean, I will point out that Judge Reed O'Connor, the same judge that was the district court in this case, did strike down the entire Affordable Care Act, as a result of the individual mandate being dialed down to zero, and that ended up getting reversed in California versus Texas,
Right.
which Solicitor General Verrilli spoke to. But I am very hopeful that wiser judges will prevail here, and we have seen it before, but we absolutely have to fight the good fight, because way too much is on the line, and so many lives are at stake with this.
That's why we're so glad that you, Andy, and Gretchen are all out there doing it. Gretchen, any wrap up for you before we go to Dr. Benjamin? All right, Dr. Benjamin.
Just to point out, we've as a nation have lost 3 years of life expectancy. And this will exacerbate that. As a nation, we have seen an extraordinary increase in individual costs for care. There's a national effort to try to reduce the cost of health care. This will increase everybody's independent pocket costs for health care. And while there are obviously this will impact communities of color, women, of lower income individuals disproportionately more, it will impact everybody. And so while it's 150 million people on any given year that benefit from this, turns out that all 336 million Americans, or people who live in this country, at some point will need these services. So it's not just even, it's not even half, it's everybody is at risk, even judges.
Even judges, they need health care. They're people too. First of all, let's give our panel a round of applause. Thank you all so much. I want to bring next up, the next panel, which is going to be moderated by my friend and colleague, Andrea Harris. Andrea is the Director of Policy Programs for Protect Our Care, and really she planned this entire event. She has 15 years of experience in federal health policy and has held senior roles in the legislative and executive branches. Most recently as Chief of Staff to my friend, Representative Lauren Underwood. She's also been a senior appointee at HHS, and she's coming up now. She is a graduate of the London School of Economics, my goodness, and has a bachelor's degree from UCLA. Andrea, take it over.
Thank you. I'm just going to switch out our panels.
Scoochie. Scooch.
Thank you, Joy, and thank you to our first panel. This panel will explore the cases that are threatening the Medicare prescription drug price negotiation program. I'll give a little bit of a history as we get started. So when Congress added a prescription drug benefit to the Medicare program in 2003, it famously, or at least famously for the people in this room, included a non-interference clause that prohibited Medicare from using its purchasing power to negotiate prices with pharmaceutical manufacturers, and instead left those pricing decisions to thousands of Medicare Part D plan sponsors and big drug companies. So it's not surprising that drug companies charge patients in the United States 3 times more on average than patients in other high-income countries. The prohibition on Medicare negotiating drug prices is part of the reason drug companies have disproportionate power in price negotiations. But that finally changed in 2022 when Democrats in Congress passed and President Biden signed into law the Inflation Reduction Act. The law amended the non-interference clause, lifting the ban by establishing a framework for Medicare to use its negotiating power to negotiate lower prices. By 2030, the Centers for Medicare and Medicaid Services, CMS, will have negotiated lower prices for up to 80 drugs. And in the budget released yesterday, the president proposed more than doubling the number of drugs eligible for negotiation to 50 drugs per year. CMS is currently negotiating lower prices for the first 10 drugs selected for negotiation, and these prices will take effect in 2026. While the negotiation process is ongoing, a parallel process is playing out in the courts, whereby drug companies and their trade groups are suing to block the Medicare drug price negotiation program. Plaintiffs have filed a total of 10 cases. One case was withdrawn when the company was not selected for negotiation. Oops. One case was filed in Texas by the drug industry's main lobbying organization, and that was dismissed in February, but is being appealed. Earlier this month, a Delaware judge ruled against AstraZeneca, stating the drug company is not entitled to sell its drugs to the government for any price it wants, which is great. There were 4 cases that were argued just last week in New Jersey. Those cases are awaiting a decision, and we have 3 other cases that are awaiting decisions. The briefings have concluded for those. That's Boehringer Ingelheim in Connecticut, Merck in the District of Columbia, and Chambers of Commerce filed in Ohio. So these cases make distinct and overlapping arguments as to why the negotiation program is unconstitutional, and we'll explore those as part of this panel. But generally, legal experts, including even a leading libertarian legal expert, say that 3 times fast, agree that these arguments really swing for the fences. Rather, drug companies are trying desperately to protect their profits and their ability to continue to charge Medicare whatever prices they want to charge. This risks keeping drug prices unaffordably high for seniors, too many of whom are already having to choose between filling their prescriptions and filling their refrigerators. So we have much to discuss during this panel, and a very well-rounded panel of experts with whom to explore these issues. Zachary Barron is the Director of Health Policy and Law Initiative at the O'Neill Institute for National and Global Health Law at Georgetown Law. He authors the Healthcare Litigation Tracker, which is a free digital resource that tracks and analyzes healthcare litigation in the U.S., and it's an extremely helpful resource that I'm sure many of us in this room rely on. Dr. Jerry Anderson is a professor of health policy and management at Johns Hopkins University's Bloomberg School of Public Health. His work encompasses studies of chronic conditions, comparative health insurance systems, and healthcare payment reform. He previously held positions at the Department of Health and Human Services and helped develop the Medicare prospective payment system. And finally, we have Dr. Christine Petrin, who is the board chair of Doctors for America and a resident in the Internal Medicine Pediatrics Residency Program at Georgetown. She has extensive health policy research experience and worked as a graduate student intern at CMS, where she helped states establish the health insurance exchanges. She's passionate about primary care, improving public health infrastructure, and demanding equity and justice throughout the healthcare system. So we will get started with a question for Mr. Barron. The government has, as I mentioned, the government has had some strong early wins in these drug industry cases, which have allowed the Biden administration to move forward with negotiating lower prices. So those negotiations are ongoing. What risk do these cases present to their ability to negotiate as they move through the courts?
Well, thank you, Andrea, and thank you to Protect Our Care for convening this wonderful event today. And it's great to be up here with very talented co-panelists. So if the pharmaceutical industry is able to succeed in any of their legal efforts to prevent the implementation of the negotiation program, it could fundamentally reshape the government's authority to manage the Medicare program and could block decades-long legislative efforts to respond to increasing prescription drug prices. Whether one of these challengers is able to win to block the whole program, or even if they're just able to pause, secure some type of temporary pause or vacate certain aspects of the administration's guidance to implement the program, the reality is that the administration is operating under the deadlines that Congress put into the Inflation Reduction Act in terms of, as Andrea mentioned, that right now in the middle of the negotiation process, they will announce the negotiated prices in September of this year, and those prices don't go into effect until 2026. And so if one of the drug companies is able to succeed in their litigation, that could mean that patients and seniors aren't able to see the savings for some of these critical life-saving medicines to treat cancer or diabetes or arthritis, and the federal government loses out on tens of billions of savings. And so, there's been a number of amicus briefs in these cases. There was one brief filed by several nationally recognized Medicare experts, and what they wrote is that the legal position set forth by the industry essentially attacks the government's ability to run the Medicare program. So there are really big stakes here at this case, both for the Medicare program and then even in terms of thinking of other types of major healthcare reform initiatives to control costs and make sure that patients can access a range of treatments that they need.
Thank you. I have a follow-up question for you. I had mentioned that there are a lot of arguments the drug companies are throwing into the courts. Can you give us a little bit of an overview of the overarching themes of those arguments and what generally, how they're viewed in the legal community, perhaps even by some of the Trump-appointed judges?
Sure. Well, I think if you wanted the full rundown, we'd be here all day. But just briefly, we see in these lawsuits that, of course, have been filed in courthouses across the country that the pharmaceutical industry is trying to leverage various constitutional doctrines like the Takings Clause, the First Amendment, the Due Process Clause, separation of powers, the Excessive Fines Clause, and of course they're also bringing different statutory challenges. And what they're really trying to do is tie the hands of the federal government from being able to achieve some of these major reforms to our healthcare system and address the high cost of prescription drugs. At the end of the day, what industry is saying, and we even saw this in oral argument, I think you may have been at in New Jersey last week, is they're saying that if they're not able to require the government to pay the prices that they demand, even if they have a monopoly in the market, that's somehow a violation of their constitutional rights. And I think, as you noted, the legal community has broadly been very skeptical of a number of these claims, a number of which are also retreads of past failed challenges that people have brought against the authority of the Medicare program in the past. And, at the end of the day, I think it's also important to say, of course, there's the views of legal experts, but what are judges actually saying in these cases? And to date, we've had rulings by 2 judges that were appointed by former President Trump, pretty soundly rejecting the legal arguments that the pharmaceutical industry has been making. We saw last fall when the Chamber of Commerce tried to halt the implementation of the negotiation program before it even went into effect. A federal judge in Ohio wrote that at the end of the day, participation in Medicare, no matter how vital it may be to a business model, is completely a voluntary choice. And I think what we saw earlier this month in the decision from the district court judge in Delaware in the AstraZeneca case, I think, as you noted, he wrote, "No one, however, is entitled to sell the government drugs at prices the government won't agree to pay." And he sort of went through both the history of the Inflation Reduction Act, why Congress took this action to take on, this, which I think Dr. Anderson might talk a little bit about why Congress sort of focused the attention on a particular narrow set of drugs that lack competition and that Medicare is spending, a disproportionate share of their expenses, and said, look, AstraZeneca doesn't like this law. Drug makers don't like this law. They lobbied in Congress. They lost. And now they've come to the courts to say that, we want to be able to still demand the prices that we had before the law went into effect. That might be a policy disagreement, but that's not a constitutional violation. And I think just one last point on this, one argument, and I feel like all these lawsuits end up being tied together in thinking about what the Solicitor General said and what Andy said on the past panel. One thing the drug makers are trying to do is tap back into the original big ACA constitutional challenge and say this is a gun to the head of the drug companies, these terms of the Medicare negotiation program. And the federal judge in Delaware really took that on and said, look, this isn't a gun to head, it's a powerful incentive. Certainly it's an important market for drug companies, but there are all sorts of business decisions that these companies have to make. And so there was oral argument last week in New Jersey, and we'll see how other district court judges resolve these cases, but inevitably they are likely going to go up on appeal.
Thank you, Zach. I would say that judges certainly are taking these arguments seriously. There was over 4 hours of oral arguments that I was privileged to witness on Thursday, and multiple judges across the country hearing even more. And of course, the advocacy community is taking these arguments very seriously too, and there have been dozens of amicus briefs filed in the various cases. Everyone, with the exception of Zach, maybe has been involved in filing them, and Jerry Anderson was part of filing one on behalf of economists. So, Dr. Anderson, I'd like to turn to you. The various plaintiffs in these cases make economic arguments about the nature of the negotiation process. Zach mentioned it was negotiation with a gun to your head. Merck's lawsuit dramatically described it as tantamount to extortion. Can you explain how Medicare's new drug price negotiation program fits into the broader framework for Medicare reimbursement and how other federal programs pay for prescription drugs?
Well, thanks for the question, and I'm a little intimidated by Zach being here because he's my boss in all these amicus briefs, and so, I want to make sure I do well today. One of the things that I haven't done well is when I came to Washington in 1978, my goal was to control health care costs. I've done a great job. I'm sure you all recognize that. But I just want to tell you sort of how the Medicare program works and how much the program for prescription drugs is such an aberration from the rest of the programs. So when I first arrived, hospitals were paid their costs. And you get paid costs, and you increase your costs, you get paid more. So that was just the wrong incentive system. And so I helped design the Medicare Prospective Payment System, which says this is how much the Medicare program will pay. Takes into account the case mix of the patient, it takes into account the cost of living, it takes into account a whole series of factors, but it essentially sets the price. And then we decided, well, we'll continue doing this because it seems to work. We also got sued, but, it seems to work, so we moved it for nursing homes and home health agencies and all sorts of other institutional ones. And then the question back in 1989 was, what do we do about physicians and other providers? And so we developed RVRVS, the Resource-Based Relative Value Scale, and we said, well, we're going to set rates for physicians. And so we moved and we did it for a whole variety of other clinical categories. So for the two major parts of the healthcare system, we essentially had rate-setting kind of systems. And then we said, well, we're missing something from an important part of the healthcare system, pharmaceuticals. What are we going to do here? And so now it's 2003. We had an option, and the option was how the VA pays for services, how the Department of Defense pays for services, and they essentially do the same thing that Medicare has been doing for a long time. They determine the appropriate amount to pay, and they look at value, and they do a whole variety of things. But Congress in 2003 said, no, that's not the way we want to try to do it. We think the private sector would do a much better job at setting rates than the government will. Now, if you looked at the data at the time, how is the private sector doing when it set rates for hospitals and physician services? The rates were double what Medicare was paying for hospital and physician services. And so, well, if I was the pharmaceutical industry, I'd say, who do I want to determine the rates for me? Well, I definitely want the private sector to do it. I don't want the government doing it. That would be terrible, because they know how to set rates. And so you essentially got the approach that we have today. And we worked a long time to try to say to the Congress and others, well, we pay 3 times more than everybody else for the same drugs. And these drug companies have these monopolies, and in economics, if you have a monopoly, you get to set the price that you want to set, and so isn't it surprising that they charge 3 times more than everybody else? And so, we said, well, what are the drugs? And so we started out in the House, and we said, oh, well, we'll look at international comparisons, and when we got to the Senate, they said, that's not what we want to do. But so we said, well, you should have a period of time that's sufficient to earn a profit, let's say 9 years and 13 years, and we'll take all the drugs after that, because we know that they're sitting there and doing all sorts of patent protections and all sorts of other games that they're playing. So we'll put a limit on it, and fortunately, we were able to get 50 Democratic senators to agree to this kind of concept. What are we doing now? Well, I'm on the Maryland Drug Affordability Board, and I got to pull up the names in a second. But I'm going to need your help very soon, because we are probably going to get sued too. And so we have identified yesterday 7 drugs that we're going to take a look at. And they are Biktarvy, Dupixent, Farxiga, Jardiance, Ozempic, Skyrizi, Trulicity, and Vyvanse. And so, we need your help. We're going to get sued slightly differently than the federal government doing, but please help us. Thank you.
Thank you. And there's some overlap in those drugs with the drugs that they're currently being negotiated by Medicare. Dr. Petrin, the next question's for you. Doctors for America, your organization, advocates for lower prescription drug costs and played an essential role in getting drug pricing measures passed as part of the Inflation Reduction Act. And your organization joined several other amicus briefs filed by Public Citizen, Protect Our Care, and others to explain to the court how the negotiation program addresses affordability and improves seniors' access to life-saving drugs. Could you explain how the high cost of prescription drugs harms patients' health and quality of life?
So I'm the chair of Doctors for America. We're a group of about 27,000 physicians, and like most of our members, I spend most of my day sitting in an exam room face-to-face with patients when they're at their most vulnerable. So I've seen how the high price of medications has a direct impact on individuals, particularly seniors. And just last week, I was actually at a pharmacy, and there was an elderly woman in front of me who went to go pick up her medications and was told they were going to be $60. And she said, I'm going to have to think about this. And I watched as she and her husband turned around and left the store. And that's not even a physician story. That's happening in our communities. This was at the Walgreens at 13th and U. So this is happening to our neighbors, to our families, and to our friends. And I think it's really important to think about the population that we're talking about here. These are folks with multiple chronic health conditions on a fixed income. The 80% have more than 2 chronic health conditions. And we're not talking about an antibiotic that they're going to take for a week. We're talking about life-saving drugs that are going to keep them alive for several decades. And we're also talking about multiple medications. It's really amazing how quickly a patient can all of a sudden be on 10 different pills every single day. Everyone's on a multivitamin, calcium and vitamin D for their osteoporosis, a statin, 2 things for their blood pressure, diabetes, a laxative, something to help them sleep, and something for reflux. It adds up really quickly. And I've seen my elderly patients ration their pills, sell their possessions, and work up to 3 jobs 7 days a week just to be able to afford their medications. And I've seen this in my personal life too. My grandmother couldn't afford Xarelto. This is one of the blood thinners that's up for negotiation. So she had to take a less effective, more cumbersome medication that required frequent lab draws and multiple unnecessary appointments. And she's not alone. 20% of Medicare beneficiaries are skipping doses or taking less than prescribed. Another 10% are going without basic life essentials to afford their drugs, and another 11% aren't even picking them up in the first place because they can't afford the price, much like the woman I saw just a couple of days ago. And when my patients don't take their medications, their health declines, they get hospitalized, and they never fully recover. And unfortunately, some of them join the 125,000 Americans that die every year from chronic disease treatment failure. And I want to specifically talk about some of the drugs that have been selected for negotiation, these first 10. Many of these particularly expensive drugs, things like Jardiance, Entresto, Xarelto, they often don't provide symptom relief. They're incredible medications. They extend life by improving heart failure, kidney failure, preventing life-threatening blood clots. But they don't make a patient feel better day to day, so they're often the first drug that's going to get dropped by the patient themselves when the price is too high. And I have had difficulty convincing my patients to start taking these medications because of the cost. And it's really frustrating to go to med school and to study pharmacology and study physiology and read all these journal articles about how effective and great these drugs are, and then not actually be able to use them despite this incredible data because they're not accessible to my patients. And it's like trying to practice medicine with my hands tied behind my back. So, we need to lower the cost of these medications to protect our seniors, and right now the best way to do that is by giving CMS the power to negotiate with the pharmaceutical companies.
Thank you for that. Xarelto was launched in 2011. It's been on the market for 13 years with a monopoly, so it's time that its price is affordable. The next question is for Zach. It's somewhat, we'll get back to talking a little bit about the cases. So it's somewhat striking that there have been over 10 cases filed in so many jurisdictions, from DC to New York to Ohio to Texas, New Jersey, Connecticut. What can explain the pharmaceutical industry's strategy here?
Well, look, I think it's fair, as you mentioned, sort of all the places across the country where they're filing these cases, to say that the pharmaceutical industry is pursuing a kitchen sink strategy to stop the implementation of the negotiation program before these prices go into effect for 2026. And as I alluded to, certainly we saw both in what the Department of Justice has written in their court filings, but also what the federal judge in Delaware said, is that drug companies like the old system and they lobbied hard to keep it. What the government has argued is that these lawsuits are really policy disagreements that the industry is masquerading as constitutional claims. And I think when we see this strategy of filing cases across the country, trying to find one judge to issue some form of nationwide relief or try and get up on appeal or one panel, that's all it takes in sort of modern litigation. And whether it's past challenges to major healthcare reforms under the Affordable Care Act or the No Surprises Act, we see that industry and other ideologically motivated organizations, they have the means to make these strategic litigation decisions, just hoping to get that success in one place. And I think the last thing I'll say is, of course, there's a lot of litigation going on right now, but last fall, Pharma's CEO said there would be a second wave of lawsuits challenging the negotiation program. And so I think there still remain many twists and turns in this litigation.
We will be following these for a while, and the companies will continue to court shop, I'm sure. So let's get back to some of their arguments, or the economic ones. So not only are drug companies trying to block negotiation in the courts, they're trying to do this through repealing the program through Congress and undermining the program through other legislation. Their claims to lawmakers is that the program is going to limit their ability to invest in new innovative drugs. They just won't have enough money to invest in new drugs. And they're taking a very different tone with investors. When you listen to earnings calls and read through their earnings statements quarterly and annually, they assure investors that they have promising drugs in their pipeline, and they point to how positive the Inflation Reduction Act will be for seniors' adherence to drugs, because of course there's a new $2,000 out-of-pocket limit, which is going to make it so much easier for seniors to stay on their drugs. And of course, drug companies like that, Bristol Myers Squibb and Novo Nordisk, two of the companies that are suing to block negotiation, last year spent more on shareholder compensation than on research and development. That was a point that judge in New Jersey made last week. He said, I need to be able to see how much money you're spending on executive compensation, stock buybacks, marketing, before I'm going to give you much credence in your argument that you won't have enough left for research and development. So can you shed a little bit more light on that, Dr. Anderson? How true are drug companies' innovation claims? And if drug companies succeed in blocking negotiation, what would that mean for their bottom line?
So our team spends probably every week, if not every other week, on Capitol Hill testifying in Congress on this particular issue. So last week it was about orphans, but the week before that it was about supply chain. Essentially, they are throwing as many different arguments to the Congress as they possibly can, and the drug companies have been able to get the Republicans to have a hearing on their particular issue. So we've been taking a look at the numbers that are being proposed. And the first thing we look at is, where does science begin? And it begins at the NIH. And they are continuing to pump a lot of money into research and development, and we hope that they continue to do so. We then look at where's the next step in most research and development, and it goes to where the NIH funds research, which is at places like academic medical centers, places like Johns Hopkins. And we fortunately get more money than any other institution from the NIH, and we're very pleased with that. But we also have the whole issue of trying to then translate our findings into drug development. And how do we do that? Well, generally what we do is we partner with venture capital firms. And venture capital firms are the ones that take the basic science that we develop at Johns Hopkins, and they use it to start the drug development process. Now, the venture capitalists are not people that are interested in new science. They are interested in making money, and that's their total focus. And so, as a venture capitalist, you could invest in Google, you could have invested in drug development, you could have invested in ChatGPT, you could have invested in a whole variety of different things. And you're going to go where the money is. And so we're saying, well, do they, the venture capitalists, which are at the beginning of the process, do they think that the pharmaceutical industry is a good investment or a bad investment as a result of the IRA and a whole variety of other things? And so we look at how much are they spending on research and development as the venture capital industry. And it turns out that the percentage is going up. They are investing more money in biopharmaceuticals this year than they did last year than they did 10 years ago. They are also putting a higher percentage of their investments. They're also putting more money per investment. So the money that they put into biopharmaceuticals is bigger than the money they put into many other kinds of things. And so it's perceived by an industry that's interested in making up profits to be a very lucrative activity. The second thing that we take a look at is, where does the pharmaceutical industry decide to spend its money? And you're absolutely correct. They're spending much more of their money on marketing, on a whole variety of things. But we wanted to see whether or not they're investing in research and development. And they are. They are investing more money as a percentage of their dollars. It's only about 10%, but it's more money than they have in the past. So they are also investing more in research and development, even as a result of the IRA, than they have in the past. It's not like they're not making huge profits and they're spending more on marketing, they're spending more on a whole variety of other activities, but they're not essentially cutting back on certain activities as well. So we're looking at the pharmaceutical industry and trying to figure out. Then the next thing we're taking a look at is, well, how much does it actually cost to develop a drug? And the pharmaceutical industry reports that it takes about $3 billion to develop a drug. So we're looking at very specific drugs and saying, did it really cost that amount of money to develop a new drug? And so we look at some of the big blockbusters that have come up on the market, and we say, anything close to $3 billion? And we can't find a drug that costs $3 billion, at least a blockbuster drug that costs $3 billion. Some of the big drugs that we talk about and especially the ones that are the orphan drugs, they cost like $40 million to develop. $40 million, not $3 billion. So we're taking a look at that particular as well, trying to figure out what's the argument here that they say that it's cost $3 billion and we're going to cut back, because they're not cutting back at venture capital, they're not cutting back in their research, and it doesn't cost $3 billion to develop a drug.
Thank you for that, and thank you for your work in exploring the claims that drug companies are making and holding that against their actions, which tend to be quite different. I've thought it's been really interesting to follow just how incongruous their claims to Congress are when you're actually looking at how much more they're investing in research and development, how they're acquiring new drug companies, small molecule drug companies, biologic drug companies for greater amounts of money than they have in the past too. These trends are running counter to what you expect they would be if you were listening to their arguments about why the IRA should be repealed. Next question is for Dr. Petrin. As a primary argument of drug companies is that the negotiation program allows Medicare to buy prescription drugs for a fraction of the drug's value. A value drug companies presumably define as whatever they want to charge for their drug based on their monopoly power. The amicus brief Doctors for America joined explains why this claim that negotiation will undervalue a drug is baseless. Could you unpack that argument for us?
Sure. So when we're thinking about value, and I should say too, the drugs we're talking about, they work, and they work really well, and frankly, some of them are miracles. But it doesn't take a doctor to tell you that a drug is only going to work, it's only valuable if a patient actually takes it, right, if they can afford to take it. And in our amicus brief, we talk about the context in which these drugs are bought and sold, and it's impossible to talk about the fair market value of these drugs in the context of a monopoly, which is what these pharmaceutical companies are, right? They have an exclusive product, they set the sales price to their benefit to maximize profit. This is a monopoly. A few other points we make in our amicus brief is that they do this all the time. You know, they negotiate with other countries all the time. It's why other countries are paying so much less for drugs than we are in the United States. I talked about Xarelto earlier, a blood thinner. In the United States, a year-long prescription for that costs about $6,000. In France, it's half that. In Canada and Australia, it's about 20%. And we don't even have to look outside the country for this, right? Like, they're doing it here all the time, too. They negotiate with the VA. I work at a lot of hospitals in this area, and it's really frustrating to me how disparate coverage can be. Thinking about the same drug when I'm at Georgetown versus when I'm at the VA. So same drug, same city, wildly different coverage. And we have these super smart experts up here, but I promise this issue is not this complex. Like, pharmaceutical companies are making it this complex, but it's actually really simple. Like, at the end of the day, we're talking about seniors affording their medications to live longer, healthier lives. Like, it's as simple as that.
Thank you. Okay, I think we have, oh, sorry, Zach, did you have a follow-up?
No.
Oh, okay.
That was great. I mean, who needs all these complicated things?
I think we have some time for audience questions. I know we have some technical challenges, so if you have a question in the room, please project your voice and I will repeat it for those in the virtual audience. And if you're participating from home, you can enter a question in the chat or the comments. Yes, we have a question over here.
We hear from providers that Medicare underpays based off of commercial rates. Will we see that with Medicare negotiations with physician drugs? Will we see that argument? And how would we see that?
So the question is, does Medicare underpay relative to commercial payers for services? Will we see that argument applied to prescription drugs?
So if I was the hospital industry, I would make your argument that they underpay. I have a totally different perspective on that same argument, and that is that the private insurers overpay. So how does this work? So Medicare decides it's going to pay $100 for something. Medicare is about half the business for many hospitals, just keep the numbers simple. The private insurers pay $200 for the same thing. Now, I'm a hospital, what am I going to do? I've got now $100 from half my business and $200 from half my business. So I've got $150 to spend, and I'm a nonprofit hospital, I'm a for-profit hospital. I'm going to spend $150, okay? And that's going to be my cost of care. Now you say, but Medicare only pays $100. Well, it's true, Medicare doesn't pay the full amount, but it's because the private sector keeps paying more and more of the cost, and that's why essentially we're seeing that somebody argues that there's underpayment. When I started this process back in the 70s and 80s, everybody paid about the same. It's that the private sector has been unable to negotiate with hospitals, and if you think about any area, you know, there's two healthcare systems in that area. And if you're an insurer, you have to have them in your network. Because in Baltimore, if you don't have Johns Hopkins in your network, how are you going to sell insurance? And so, you know, essentially the providers have all the power. You know, I back in the 1980s or early 90s, the argument was Medicare and the private, and we have to pay more in the United States because other countries pay less. And my argument at that time was, well, if I'm the CEO of Pfizer and I talk to the French manager of France and I say, did you get as much money as you possibly could from France? And he says, no, because you made so much money in the United States, you would get fired. And so, you know, essentially they're getting the maximum amount of money they can from every single component of the industry, in the pharmaceutical industry or hospitals or anybody else. And you know, wouldn't expect them to do anything differently. But, you know, they're maximizing their revenue in each sector.
And I think it's important to point out that drug companies accept different prices for their same drugs based on who they're selling it to already in this country, even among government payers. So the VA is not paying what Medicare pays. The Medicaid programs aren't paying what commercial payers pay. So I think that, you know, the arguments will continue.
We also have the price transparency data for every single hospital in the United States, and we look at the drugs that they pay. And for United, they can pay 6 different prices for the same drug at the same hospital.
That's a whole other panel. Any more questions from the audience? Bailey.
Yes, hi. Thank you so much for holding this panel. Maybe like a little bit trying to like look ahead and read the tea leaves. Since we have all these various cases across various courts, like as they kind of potentially move up into various appeal courts, do you think there's a chance that they might be consolidated once they reach a high enough point into one case, or are we going to like continue to play whack-a-mole across various courts?
So, you know, I think, as I mentioned earlier, there's a reason why they filed these cases in a bunch of different courthouses, and I think the general view of industry is, you know, they, I think, recognize that, you know, the existing precedent and sort of case law that district court judges are going to apply is not friendly to them. As I said, there are a whole host of past constitutional challenges to the authority of Medicare in which, you know, providers, you know, other organizations have filed and lost. Now, the traditional view is, you know, you file cases in multiple places, you go up on appeal, you get sort of a circuit split, and then that gets up to the Supreme Court. And so, you know, I think certainly their whole strategy is to try and, you know, move this up to the appellate courts, try and get this to, you know, to the Supreme Court. You know, at the same time, the Supreme Court is taking fewer and fewer cases, you know, these days than they have in the past. And I think, you know, if the government were to win all these cases at the district court or the appellate courts, it's not entirely clear to me that the Supreme Court is definitely going to rush and take this up. But, you know, certainly I think we are, you know, going to continue to play whack-a-mole a little bit as these move up through the appellate courts.
If there are no additional questions, would like to thank the panelists, or any parting thoughts?
No.
Okay.
So I'll just quickly say that this is the tie that I wear in almost all of my testimonies. It's Leonardo da Vinci. It's backward writing in Latin, and I think it explains how health policy works.
Perfectly noted. Thank you. Right, I'd now like to welcome our third and final panel to the stage. This panel will explore the cases that seek to overturn FDA's approval of mifepristone, which would threaten access to safe abortion care and open the door for politically motivated destruction of the FDA approval process. Yvette Fontenot will moderate the panel. Yvette is a senior advisor for policy and legislative affairs for Protect Our Care. She has nearly 25 years of federal healthcare experience and has held senior positions on Capitol Hill as well as at the White House and HHS. And she served as a senior advisor in the Obama White House, as well as the deputy director of the Office of Health Reform. She also is an architect of the Affordable Care Act. So welcome to the stage.
I have nothing to do with this panel, but I just want to say that we're expecting Senator Klobuchar to arrive sometime in the middle of the panel, and we'll ask folks to we'll interrupt so she can make her remarks when she arrives. Thank you.
Okay, batting cleanup. Mifepristone. We're for it. Yes, we are for it. Been around for a while. On the 26th of this month, the U.S. Supreme Court will hear arguments in the case that risks chaos in the U.S. drug approval system, which is the gold standard for the world. The suit brought by Alliance of Hippocratic Medicine and their attorneys at the Alliance Defending Freedom against the Food and Drug Administration seeks to overturn the FDA's nearly quarter-century-old approval of mifepristone, which is perhaps better known as the abortion pill, and has a strong documented safety record and is used in more than half of the abortions in the United States. So clearly, access to mifepristone has become even more critical in the nearly 2 years since the Supreme Court struck down the federal right to abortion care. If the Supreme Court allows the Fifth Circuit ruling to stand, the decision would upend the FDA's ability to allow a drug's approval to keep pace with scientific evidence surrounding its use. It would open the door to politically motivated plaintiffs and judges to challenge the science-based FDA approval process. As detailed in the December 2023 report by Protect Our Care, this could lead to the public losing access not only to medication abortion, but also to contraception products, vaccines, treatments for gender-affirming care and HIV prevention, innovative cell and gene therapy, and more. In this panel, we're going to explore these consequences in depth and hear from expert panelists who each bring a unique perspective on the health care that this puts at risk for Americans, and why the Supreme Court must reject the plaintiffs' arguments in full. So Carrie Flaxman is a senior legal advisor at Democracy Forward. She joined Democracy Forward after nearly 2 decades as a litigator at Planned Parenthood Federation of America, where she was most recently a senior director of public policy, litigation, and law. At Democracy Forward, Ms. Flaxman supports the organization in crafting legal strategies to advance the rights of all people and to stop attempts by governmental actors to undermine our democratic values. Thank you for that. Jocelyn Fry is the president of the National Partnership of Women and Families. Under her leadership, the organization is focused on advancing economic justice, affordable and equitable health care, civil rights, and reproductive freedom for women who face the steepest barriers, including women of color, women with the lowest incomes, women with disabilities, and transgender women. Ms. Fry began her legal career at the firm of Cromwell & Moring. She received her JD from Harvard Law School and her undergraduate degree from the University of Michigan. Go Blue. And Bill Schultz is a partner at Zuckerman Spader. During the Obama administration, he was the general counsel of the Department of Health and Human Services. During the Clinton administration, he was Deputy Commissioner for Policy of the Food and Drug Administration and Deputy Assistant Attorney General of Civil Appellate at the Department of Justice. Previously, for 5 years, he was counsel at the House Subcommittee on Health and Environment, and for 14 years, a litigating attorney at Public Citizen Litigation Group. So thank you so much for being here with us. Ms. Flaxman, I'm going to start with you. Can you walk us through this case to date? What are the plaintiffs seeking, and what is the Supreme Court considering in this case?
Sure, happy to. And I know that a lot of folks are familiar with this case because it's been kicking around for a while, but with the oral arguments coming up on March 26th, as Yvette said, it's good to get a refresher in. And so this case started within months after the Dobbs decision. There was a whirlwind of activity last April where the federal court judge who has the case, Judge Matthew Kaczmarek, stayed the approval of the medication entirely. And the Fifth Circuit Court of Appeals largely agreed with him, although walked back the order some. Ultimately, the U.S. Supreme Court blocked that order staying the drug's approval while the case proceeded. So at this point, the medication remains available. The Fifth Circuit, the Supreme Court's vote only had 2 noted dissents. And so then the case proceeded in the lower courts, and it's now back before the Supreme Court. So, as Yvette said, it's probably worth, mentioning just how safe this medication is and how widely used it is. It's been used by over 5 million people. It's not only been approved for 23 years, but over 5 different presidential administrations. The FDA has carefully considered the drug's safety and updated its prescribing conditions when the record showed that was warranted. And so, it has a well-established safety record, again, over 5 million people who have used it. It's really one of the safest drugs on the market. So with that said, the Supreme Court is largely going to consider 2 issues. First, the court is going to need to consider whether the plaintiffs, who are physicians who are opposed to abortion, not prescribers of the medication, the court needs to consider whether they have what's called standing, which is the legal test for whether a party has the right kind of injury to come to court to challenge something. Notably, the first named plaintiff, the Alliance for Hippocratic Medicine, was incorporated in Amarillo, Texas, just mere months before the case was filed. And that happens to be where Judge Kaczmarek sits and gets 100% of the cases that are filed. The plaintiff's claim to standing is based on plainly, frankly, junk science that they have put before the court that suggests that patients who have taken mifepristone are experiencing so many complications that those patients will arrive at an emergency room where these physicians might be practicing and need them to provide care. That chain of events is speculative enough where it's difficult to mount standing, but particularly so when the science on which the claim is based is not in any way evidence-based. Notably, the publisher of two of the studies on which Judge Kaczmarek relied recently retracted them because of undeclared conflicts of interest, and after expert reviewers found that the studies demonstrate a lack of scientific rigor. So that's the standing question. The second issue the court will consider if it decides that the plaintiffs do have the right to be in court is whether the FDA, this is on the merits, whether the FDA properly revised the conditions for use of mifepristone in 2016, and whether the FDA properly eliminated the requirement in 2021 that the drug be dispensed in person in a clinic. Now, as I mentioned, Judge Kaczmarek would have suspended the approval altogether, but the Fifth Circuit limited the ruling to the 2016 and 2021 changes. The Alliance for Hippocratic Medicine asked the Supreme Court to review the approval piece, and the Supreme Court denied it. So at least at this point, the two merits issues before the court are on the 2016 and 2021 changes. The 2021 change is particularly notable given the use of this medication for telemedicine, along with all sorts of other medications that are safe and appropriate for that use, and also the recent changes that have allowed certified pharmacies to dispense the medication. I think that one of my co-panelists will get into this in more detail, but what the lower courts did below was utterly fail to defer to the FDA's scientific judgment that the changes that it made were appropriate and that the drug is safe and effective. And in doing so, as far as I'm aware, it is the first time the courts have second-guessed the safety decisions that FDA has made in approving a drug.
So much broader consequences for the FDA.
Correct.
That's very helpful. Bill, I'm going to calling you as a former FDA regulator to this point. What's your perspective on why Americans across the country should be concerned about the potential outcome of this case? What are the implications for the drug approval policy if the court overturns FDA's evidence-based modifications since the original 2000 approval?
Okay, so I make 3 points. One is overturning the FDA's decision. In the end, it's going to really diminish the confidence that patients, doctors, and health professionals have in the FDA drug approval process and thus in drugs approved by FDA. As everybody probably knows, FDA's job with respect to drugs is to determine whether they're safe and effective. And this is done after a drug is tested for many years, after a very sort of complicated application is submitted, and then after FDA experts review all of that. And these are people with expertise in statistics, they're physicians, they're pharmacologists, and biologists. And then after all of that, it's often sent to an outside advisory committee, a committee of outside experts who again review the data and give FDA advice on whether the drug should be approved. As has been mentioned, but this is critical, always before, when
a court reviews an FDA's decision, and a drug company, in some cases somebody else, can challenge an FDA decision. But always before, the courts have taken the view, we're not scientists. We don't have the expertise to decide whether that drug trial was statistically significant, for example. And so while we'll review the decision, we're going to give a lot of deference to the administrative agency, to the FDA. And we'll look to see whether they did something that's arbitrary, obviously really a huge mistake, whether they explain their reasons adequately. But basically, barring something really unusual, the FDA is going to win, which is why there aren't that many of these cases. I mean, drug companies, in many cases would love to get adverse decision overturned, but they know that that's not very likely. Same with public interest groups who may disagree with an approval. They also know it's not very likely. So historically, there are only two cases that I could find where a court has ever overturned an FDA approval decision. And one of them is this case. And in each case, those decisions were reversed on appeal. So in the end, it's really never happened up to now. But what the Fifth Circuit said is, we're not going to give that kind of deference to the FDA. We're smart. We're going to look at it ourselves and see where the FDA went wrong. And as has been explained, they found a number of places where they think the FDA went wrong. So that's the first impact. It really undermines the faith in FDA and in drugs if courts are going to be overturning it. The second one is on sort of the FDA process itself. Any drug approval is based on hundreds of judgments. And so it's not that hard to sort of start second-guessing a few of them, particularly if the court is willing to review it without the kind of deference I was talking about. So we'll allow the court to look at, well, was that trial statistically significant? There were 2 deaths. The FDA decided they weren't connected to the drug, but maybe we think they were. Was the trial large enough? Did the patients get the right informed consent? Or here, there were changes about who has to report adverse reactions. The FDA decided one way, maybe the court thinks another way, which is actually what happened here. So the inevitable result in terms of FDA is it's going to kind of back up, I think. It will require more studies. It will hesitate on approving, say, improvements to drug labels, and it will be slower in making its decisions. And the consequences of that is going to be to patients when we're talking about life-saving drugs. And then the third is, this will chill investment into life-saving drugs. Pharma, the trade association for the drug companies, filed an amicus brief advocating for reversal of the Fifth Circuit. So this is kind of unusual, where you have public citizen, public health groups, and the drug companies all together. This is a little different from the last panel that you heard, but it's significant. And hopefully the court will take notice. But I have the figure of $2 billion for development of drugs. We heard $3 billion in the last panel. And there are a lot of doubts about whether it's $2 billion or $3 billion. But it's a lot of money. I don't think anybody doubts. It costs a lot of money to develop some of the most important drugs that we have. And it's also true that only 12% of drugs that undergo clinical trials, which is the expensive part, are actually approved. So what Pharma said in its brief is that affirming the Fifth Circuit will add uncertainty about its research and uncertainty about whether it can get drugs approved, and if it gets approved, whether that approval will be sustained. And so it will do less research, which means less approval of life-saving drugs. Now, there's a second impact that Pharma didn't discuss, but I think is really important, and that is another way Pharma can spend its money is by extending patents. And a lot of money is spent to block generic drugs, to keep drug prices high. And if it turns out that your basic research is now less profitable, money's got to go somewhere. It's going to give you the incentive to spend it on keeping your prices high. And so that's another adverse effect. So in summary, the effect is that confidence in the safety and effectiveness of drugs will be eroded, and the interest in investment in life-saving drugs will be diminished.
Yeah, those are pretty dire consequences. I just want to draw out your first point a little bit. What happens when faith in the FDA is undermined? What does that mean for consumers in your perspective?
Well, I mean, we're getting into speculation now, but, I think it means, we see a lot of skepticism about public health and drugs. I mean, you really see it in vaccines today, right? And so, many people in this room are fighting that and working to counter it, and it will make it harder. There will be, I think, the risk is there'll be less faith in approved drugs. People will be more likely to turn to dietary supplements and alternative remedies, which, if you have a serious treatable disease, is a public health disaster.
Ms. Fry, so given what Mr. Schultz just said about the FDA's drug approval system and how it could face serious disruption if we get a bad ruling from the court here, can you, given your observations of this Supreme Court, especially in the Dobbs ruling, how do you think the court would consider questions it's being asked to rule on in this case? Do you think the popularity of mifepristone, about 2/3 of U.S. adults say it should be on the market, will influence the court's decision?
Thank you for the question. So I don't think popularity per se, and I'm not sure I would argue that popularity of the drug is what should drive their decision, but I do think Dobbs gives us some clues, and some of those clues are concerning because really to pick up where Bill left off, people do rely on the FDA. They rely on science for a number of decisions, and they rely on consistency in the law. And what Dobbs did is upend that entirely. And when you look at that decision, what you see is that many of the factors in traditional ways you would expect the Supreme Court to look at that case, they threw out the window, and arguably because there is now a conservative wing on that court that has a different agenda in mind. So, the long-standing precedent of Roe, the science that informs the implications of simply eliminating access to abortion care, all of that the court largely not simply dismissed, just disregarded as irrelevant. And I think they took the position that you could simply eliminate access to abortion and there would be no other effects. A naive view, and one that there was ample evidence to show that that was not going to work, which raises a serious question about what was the agenda to begin with. And now, in the wake of Dobbs, we see the ramifications of that. We see that in terms of the cascading effects on access to different types of drugs. We see it in terms of access to care, in terms of OBGYN care in states that have very restrictive policies. We see the potential effects on things like maternal health. If folks can't get to an OBGYN, then they can't actually get the health care that they need. And even this case and other cases, the IVF decision, the EMTALA, they're now a series of cases where people are challenging rules and policies and laws that have been in place that people have relied on to access care. So will the court now look at the error of its ways and function differently? Unclear is perhaps the best way to put that. I do think the added layer here of being able to rely on the FDA's considered judgment, the science and the research that is done, not simply over months but over years, is something that you would like to think that the Supreme Court would not sort of dismiss
But we also know that Justice Alito in the Dobbs decision was really willing to dismiss a lot of that research. And so I think it is of great concern that the court took that approach in Dobbs. What I would also say, though, is that I think this court is sensitive to the public perception that they are driven by ideology and not by law. And so I think it is useful when people speak up and speak out and say that the court is not adhering to what I think are the popular expectations of its ability to look at a legal question objectively and not simply be swayed by sort of political preferences or their own ideological preferences. There have been moments and times where it seems that the justices are sensitive to that critique, but the real test is, not necessarily the popularity, but what I would say about it is mifepristone is widely used. People have used it. It is extraordinarily safe, and people, in sort of thinking about the healthcare choices that they have available, have come to rely on that as well. The other thing is that it is a tool that has, also now part of sort of the evolution of healthcare practice. It is something that can be used in the context of telemedicine. And so as we see healthcare practices become more accessible to more groups of people, it is troubling to see any reversal that is going to make it harder to access care. Will the court pay attention to that this time around? I hope so. I mean, what we would argue is simply they ought to, look at precedent. They should look at the law. They should look at the informed judgment of the FDA and rely on sound science. And if they do those things, then it should be an easy decision. I am an eternal optimist, and so I would like to believe that not simply that's the right thing to do, but if anything, they should see what Dobbs sowed. Because I think the reality is that their premise in that opinion was fundamentally wrong for a lot of reasons, but it was clearly wrong that you can simply eliminate access to one procedure and not have other effects. And we continue to see that across the country. They should see it. If there was any doubt about it, they should see it now. And I think if the decision is not sort of doesn't go in the direction that we are suggesting, it really raises questions about what is it that you can rely on from the Supreme Court. If they're not going to look at the evidence, if they're not going to look at the data, they're not going to look at the science, if they're not going to sort of look at very specific questions and not sort of broad sort of ideological agendas, like if they're not going to do those things, then I think people will look at the court differently, and that hurts all of us.
Yeah. That's a great point, that the ramifications of the Dobbs decision just keep coming and coming. And where I don't know if they were anticipated or not by the Supreme Court, but you would think that they would take a look at that and how that's played out, and it would inform this decision, hopefully.
You think so?
You would think so. One can hope. Ms. Flaxman, turning to you, given your work with a mifepristone manufacturer, if the Supreme Court were to rule in favor of the plaintiffs, what impact do you think the ruling would have on pharmaceutical innovation and production of generic drugs? Bill talked a little bit about this, but if you could expand on it, that would be helpful.
Sure, I'd be happy to. And we are representing, Yvette was referring to the fact we're representing Gen BioPro. Manufacturers the generic version of mifepristone, and we filed an amicus brief on behalf of them, along with the 30-plus something amicus briefs that were filed in support of the FDA in the case. Bill touched on oh, sorry, happy to. Is that better? Bill referred to a number of the impacts. I did want to highlight one thing in particular, or an important thing to highlight. I mentioned at the beginning that the overall approval of mifepristone is not technically before the court, that what the court is considering is the lessening of some restrictions and actions the FDA took in 2016 and 2021. I want to be clear that even if things go badly, and I share Jocelyn's optimism about this case, but I worry that the court might already feel like there is a compromise that it has landed on, given that the overall approval isn't before the court. So, but I want to be clear that even if the court orders those restrictions reimposed, that is a huge threat to access to mifepristone, given access to telemedicine. But it is also continues to be a threat to drug approvals, not just of that drug, but of really everything on the market. And and in two different respects, and the brief that Bill referred to that the pharmaceutical industry submitted discusses this. But as I mentioned, there was what some believe to be invented standing in this case, and if the court allows these plaintiffs to go forward, it really could open the door to a floodgate of potential plaintiffs, not just people who might be injured by the medication or a competitor, but really any group could create a nonprofit, perhaps in a favorable district, and file a lawsuit without really showing the kind of injury that courts have required. And in fact, as this case shows, potentially with evidence that lacks scientific rigor, that folks were able to find an outlet to publish. And so that is particularly troubling in terms of ensuring that reliance both for the industry in terms of innovation and also consumers to be able to know that the medications on which they rely remain available. And then secondly, it's the second guessing of the FDA that would extend not just to putting these restrictions back into place, but drug approvals generally. As Bill mentioned, if you're going to, as a judge, going to play regulator, there's a lot of sort of lawyers can poke holes in anything, and so there is a lot of mischief that a judge who is not scientifically trained as the FDA is, and particularly so in this case. One element of the case that we haven't touched on at all is that this case is up before the court on a preliminary injunction. The court doesn't even have the administrative record that was before the FDA in making the decisions. And so what the court has is a handful of studies that have been supplied by the parties, and to not even send it back to the agency for further consideration. What the Fifth Circuit has said is that FDA has to reinstitute these restrictions without even having the record before it. All of those things open up all sorts of drugs to litigation, introducing uncertainty into the drug approval system, industry's willingness to spend the money to innovate, and ultimately the ability of consumers to rely not only on mifepristone, but a whole host of other medications.
And for the generic drug industry in particular, which helps reduce, of course, drug costs for umpteen consumers, what are the implications specifically for that industry?
Well, I think it's in the industry relies on the determinations that FDA makes. Mm-hmm. Anytime there's the FDA approval of a product, whether it's a NDA, supplemental drug application, and then an ANDA, the industry relies on those decisions. And if they're able to show that the product should be on the market, the FDA's decisions should be enough to allow them to continue to sell their product, and mm-hmm. it just introduces uncertainty into the entire industry if that can no longer be relied on.
Mm-hmm. That's helpful. Ms. Fry, can you talk a little bit about how the advocacy community, including healthcare providers, are responding to this case?
Well, there are concerns for a number of reasons, but, one of the things that we already alluded to in the wake of Dobbs is that you see not simply the contraction in terms of access to abortion care, but the effects on other sorts of care, because people are unclear about what the law requires. After Dobbs, you now have, it's 26 states that have restrictive abortion policies. They're all different. And the decision spurred those who are really interested in curtailing access to any sort of reproductive health care to then sort of the sky's the limit. There are all sorts of restrictions out there, and doctors and providers who are not lawyers are incredibly concerned when they now have state laws that could put them in jail for 5 years. Even when they are, uncertain, and, I think the court in Dobbs and in many of these restrictive policies, they lack an understanding of how healthcare works, right? It's not like you can just pick a thing and say this is the thing, and there's nothing else that might happen. And so a person who is experiencing a pregnancy emergency may present one way, but when they start treating that patient, discover I need to do something else. And we've seen time and time again that in states where there are restrictive policies, their doctors are uncertain, and then they've sent people out the door and said come back. They've had to consult with administrators when they could be losing time, right? Like those are the types of things, practically speaking, that are happening today. And I think a decision that, again, discounts science, discounts all the processes that were used to approve mifepristone, and to instead sort of rely on specious arguments at best to constrain access. I think it has a lot of concern for many people about the access to care. And I want to piggyback on Carrie's point that we're focused on reproductive health care because, the broader context of the risk of stating the obvious, there is a broad attack on reproductive health care happening, right? Like this, abortion is the Dobbs decision, but, contraception is at risk. There are a whole host of attacks that are happening, driven by, an ideological agenda on the part of, certain constituencies in this country. But the ramifications go well beyond that, right? It's not just about the approval of mifepristone. If you can revisit a, decades-old approval process on mifepristone, you can do so on a cancer drug, on an Alzheimer's drug, on HIV/AIDS drugs, like anything that is, people perceive to be controversial or that they just don't like, they potentially can revisit. So I think the risks are enormous, and it will jeopardize the access to health care for women in particular across this country. And I would say women of color in particular, who often now are disproportionately affected by these restrictive policies. And so what we know historically, when you look at things like Black maternal health, where there are already existing disparities, to then create a scenario where they don't have access to an OBGYN on a regular basis just exacerbates those problems, right? So I think that's the concern here, and it's a significant one. And the last thing I would say is that, one of the things that was most frustrating in Dobbs is that those sorts of implications were explicitly put before them, right? Like, people knew this about access to abortion, and the court sort of dismissed it and paid it, like, in a couple paragraphs. Like, it just sort of said, it's interesting, but I don't want to talk about that, right? So that's the concern here, and I think many groups across the country are raising alarms about the effects to healthcare more broadly.
I'm going to, as promised, I want to interrupt for our special guest, Senator Klobuchar, who's come, as I hope folks know, is the sponsor of this event. Her staff and her office made this all possible. I can't think of a more fitting sponsor for this event, because the senator's been a healthcare champion her entire career in the Senate and before that. And you couldn't have a better champion or fighter on your side, because this senator is a senator who does the work. She understands the issues in great detail. She fights in the public arena. She's willing to stand up in the caucus and make her case, and she's got endless amount of energy. So if you're in a fight, and a tough fight, this is the gunslinger with a advanced degree that you want to have on your side. So thank you very much.
Well, thank you so much, Leslie. Thank you. He also did mention that our daughters are best friends, but that, and his daughter's getting married, is that right? Yeah, and my daughter's in the wedding, but none of that is relevant because I was doing this work before they ever even met. So I know their family well, and I know what a great leader Leslie is. I want to thank all of our panelists who are up here. I heard you had some great words earlier from Don Verrilli and many others, so thank you. First announcement, as we proceed with these all-important Medicare pharmaceutical negotiations, first announcement is we kept the government open and we didn't shut it down. You're welcome. It is a low bar, however. But actually that would have affected the work that we're doing right now. And so I was very pleased we were able to get that done, with more to come, obviously, with this March 22nd deadline before us. So that's very much on our minds. But I know that you will have our backs through that, and also the work that you have done, because Protect Our Care protected the Affordable Care Act, first of all, from efforts to repeal it, gotten a historic number of Americans covered by the ACA, and been critical in the fight to lower prescription drugs. Because bringing down the sky-high cost of life-saving medication has long been, as Leslie explained, one of my top priorities. I introduced one of the first bills. I only had a few people that did it with me, and then it got bigger and bigger, up to, I think, 34 people, but who's counting, in the Senate. And it is because we know that Americans have long paid the highest prices in the world for prescription medications. And a lot of it has to do with the Sweetheart Deal that was written into law before my time, I will say, and that is part of our law now. And when something's part of our law now, that means you can change it, no matter what the pharmaceutical companies say. Drug prices in the U.S. are more than 2.5 times the prices in other industrialized nations. The average price of the 25 brand name medications that Medicare spends the most money on has tripled since the drugs hit the U.S. market. And as we all know, it's not just about those numbers, as I'm sure you've heard today and know in your own lives, it's about the people. Like Kerry and his wife live in Cloquet, both take Jardiance. It costs them $750 each for just 1 month's supply, and that's on top of the cost of their other medications. Sandra, another Minnesotan who was prescribed Entresto for heart failure and Novolog for diabetes. Due to high cost, she said she had to prioritize the heart stuff over the insulin because the heart stuff is more immediate. So she's having to be her own doctor and ration her drugs. Once her blood sugar got dangerously high, and she ended up in the hospital for 3 weeks. Of course, this makes no financial sense for her, and it makes no financial sense actually for taxpayers. And that's why it's so unacceptable, and why we push so hard in the Inflation Reduction Act to get the drugs negotiated. I would have done more all at once, more drugs, and in fact, Senator Sanders and I have a bill to do just that. And the president, as you know, in the State of the Union, called for more drugs to be negotiated. But as it is now, I really am pleased that HHS picks such major drugs, blockbuster drugs, for their first 10, including drugs like Jardiance and Januvia and Xarelto and Eliquis. I'm just impressing you because I've memorized all of them, because every crowd I speak to, it kind of resonates. And one of the other things we've learned from that bill, when we set that $35 per month insulin limit, we would have loved to have rolled it out to non-Medicare, younger recipients as well, and were blocked by some of our colleagues from doing that. That has actually happened with some of the drug companies offering those rates to non-Medicare recipients. That's relevant because one of the arguments I've always believed in is once we get these Medicare drugs negotiated, it will help with the price of other drugs for others as well, given what a large user group seniors are. But right now, those 10 blockbusters, this is one of my favorite numbers to use in the world. In 2022, a combined 9 million seniors, just for those 10 drugs, shelled out $3.4 billion for just those 10 drugs in 1 year. So it just gives you the sense of the kind of money and the kind of dollars that we are talking about. So are you surprised that the pharmaceutical companies have sued? I think the answer, because you think, wow, that's bad for PR. Why would they do that, especially when the law seems so clear? Well, let me explain that again. 10 drugs, $3.4 billion shelled out by 9 million seniors. So they're trying to stop it. Multiple lawsuits have been filed by companies like Johnson & Johnson, Merck, Bristol-Myers Squibb, Astellas Pharma, as well as the industry trade group, Pharma. In the years ahead, I think we're going to see a lot of that, and that's why it is so important to focus not just on what we have passed and will pass, and as you know, it's 10 drugs and then it's 20 more and 20 more, so you're going to see more and more of it coming down the tracks. And expanding on that, it's also really, really important in this case to focus on the implementation and fighting these lawsuits every single step of the way. Because if you haven't noticed, sometimes the courts have been throwing things out. I think we have an excellent, excellent legal case on this one, as I'm sure you've heard today, because of the fact that Congress wrote it into law, the sweetheart deal, and now Congress, as is our right, made a change. And so, but none of this would be possible, this fight, without people standing with us. I always thought it was so interesting that Medicare negotiation, people actually understood it, not just Medicare, not just that pharma was too expensive under Medicare. Because my colleagues and I had run on it for so long, people actually, and it showed up in polling, understood the issue and what it was. And I just remember standing in front of our caucus going, okay, I guess you guys have just been too good of messengers, but at some point we need to deliver. We delivered big time, and we are delivering now. And I want to thank you, because without that kind of advocacy of organizations like Protect Our Care and of all of you that care about this, it wouldn't have happened. So have a great rest of your panel discussion, and thank you so much for the work you do. Thank you.
Thank you.
Great, thank you. Perfect interruption. Okay, Ms. Frey, I just want to come back to you for a second, because as the senator was walking in, you were talking in particular on the impact on women of color, and just want to give you 2 more minutes to finish up that thought, if you had additional thoughts on that, because it is that is an important angle here to explore.
Well, I thank you for that. I will just, say we could spend a whole panel just talking about racial disparities in healthcare, and particularly the effects on Black women and Black maternal health. There's lots of conversation about those disparities, and I think what is clear is that there are a range of problems, systemic problems in terms of access to quality care that results in these sorts of sharp disparities. And the ability to access abortion care and, reproductive health care writ large is a critical piece in enabling Black women and women of color more broadly to make health decisions for themselves. And one of the problems with Dobbs, among the many, is its failure to really understand the broader healthcare effects. And so it's not simply access to abortion, it is, as we were discussing, the diminution of access to OBGYN care in states with restrictive policies. And I think we should understand that Roe was an important marker, but Roe in and of itself didn't actually solve this problem, right? So when we think about what the solution is, obviously you want Roe because it was a way of securing access, but there are other things that we needed to be doing to ensure access to reproductive health care. So I think, as we look at this decision that is troubling because the court raised it, the broader question is not simply these specific legal questions, but it is what is the environment that is being created for patients writ large. And in a community, in a world where we already had problems, these decisions have made it worse.
Very helpful. Bill, I want to turn to you, given your expertise as a former HHS General Counsel and Deputy Commissioner at FDA. How would you expect an adverse ruling by the court to impact FDA's work? Would you expect the government then to be in a position of having to defend more cases seeking to overturn drug approvals, and how would that play out?
Thanks. We filed an amicus brief on behalf of 7 former FDA commissioners. And the reason they wanted to say something in this case is because they saw a very serious adverse impact on the operation of the agency should the Alliance for Hippocratic Medicine win this case. And there are 2 legal principles that Carrie explained well, but I just want to mark them again because it's so easy to just kind of, standing deference. Those are, kind of boring terms. But basically, the standing issue here is about who can sue. And, the theory here is that these doctors might get a patient who might have a rare adverse reaction from mifepristone. And I think a lot of people would say if this kind of group representing this kind of doctor can get standing here, it's going to be very easy for others to sue. So that's number one. And then number 2 is what I talked about, deference. Like, how searching is the court's inquiry into FDA going to be? Should the plaintiffs prevail here, and you've heard some of this before, but just in terms of who could sue, companies who are denied approval might think they have a good case. Companies who want to challenge a competitor. Virtually any healthcare provider who's unhappy with an FDA decision. Interest groups, for example, groups that oppose vaccines. Patients who've suffered rare events. The list goes on. And so what this means is FDA is looking at potential flood of lawsuits that it's never had to experience before. So that being true, then you say, well, how is this going to change the way FDA does its business? Because this is an agency that's very sensitive to losing cases. It hasn't had to worry about it in this area, but it's going to matter. And so if courts are going to second guess the hundreds of decisions FDA makes, and there's a serious prospect of those decisions being overturned, then the agency is just going to increase its bureaucracy, increase the number of people looking at decisions, increase what it's going to require the companies to do, and it's going to slow down the drug approval process. And then finally, after approval. So I think this decision really opens the door to what happens after approval. You know, here we are 20 years, more than 20 years after approval. And FDA is constantly getting adverse reaction reports from companies. And so based on those reports, you could have another whole range of lawsuits trying to get drugs off the market or trying to challenge FDA's decisions. So thank you very much. I want to thank Protect Our Care. I think you put on 3 terrific panels.
Thank you, appreciate that. We have a few minutes left for audience questions, if folks want to jump in. Yeah.
Hi, I'm Therese Mead. I'm with CNN. I know we spent a lot of time talking about standing, but I just want to go back to it one more time. This court has shown that it's going to accept really aggressive theories of standing, like in the wedding design case and the loan case. Is there anything you see in the tea leaves in this court that would suggest that this FDA case is going too far and that they would be wary to bring up this purpose? I mean, you talked about sort of the negative impact, but is there anything you see in this case that goes too far from the traditional court to bring up standing like this theory of standing?
There you go. I'm going to use this one.
Oh. Jocelyn had the touch. I think there are I think there are a couple of things that give me some optimism in this case. One is, as Bill referred to, the sheer range in the amicus briefs that were filed, ranging from, again, the pharmaceutical industry, healthcare advocacy groups, not the usual groups in an abortion-related case filed amicus briefs in this case. And I think that will say something to the court about the need for them to rule for the FDA here. And we saw just 2 justices note the dissent last April when the court issued the stay. There's obviously no way to know, and as Jocelyn stated earlier, obviously the damage that the court did in Dobbs is significant. I don't think the court believed it was going to have 2, not just 1, but 2 abortion cases before it, only 2 years after the Dobbs decision. This idea that they were just sending the case, resolving the abortion decision, sending it to the political branches, getting out of the abortion business, proved that it was not actually the case since they have 2 cases before it. And we are just going to have to wait to see what the court does in probably end of June.
Anything to add?
I agree with everything Carrie said. If you want to be optimistic, and I like Jocelyn's optimism, and you're on the court, and ruling against the petitioners here is really a ruling in favor of an abortion drug. And if you don't want to rule that way, you don't want to rule in favor of abortion, one way to get out of it is by standing. Is to say they don't have standing, we don't have to decide this issue.
The only thing I would add is that I said earlier that one of the critiques of this court is, particularly with Dobbs, but not exclusively so, its willingness sometimes to look past longstanding law to render its decisions. I don't think the court likes the critique that the conservative wing is ideological and not driven by sound legal reasoning. Does it stop them sometimes? Who knows? Who knows? Whether, as you say, is it a bridge too far? Who knows? I will be the eternal optimist, and I share the views of my co-panelists, but I also recognize that if it does go in a way that would constrain the FDA, I think it opens the door to the critique of them even further. And whether or not that stops them, I don't know, but I know that they're sensitive to it. right? Like, I don't think they like that perception, particularly with the many other things that have happened with the court and around ethics and so forth. The notion that the highest court in the land is not motivated by anything but the record being presented to it and sort of a sound, constrained, review of the law and precedent. That's what the court is supposed to be doing, and the perception that it's doing anything but that is not something they love. So, we'll see.
I think we maybe have time for one more question, if there is one.
As you mentioned, the Alliance for Hippocratic Medicine is arguing that the Comstock Act also would bar the mailing of medications. For those who don't know, Comstock was a Victorian-era anti-vice crusader, and I would point you to an amicus brief that was filed in the case by a number of former Department of Justice officials, as well as the Department of Justice brief explaining how that law hasn't been used against legal abortion. And I think the important thing here is and this case as a whole is an example of it. The goal here was never just to send the issue back to the states. It was to ban abortion nationwide. That was the goal with this case in terms of taking the drug off the market. And so whether that be with the attack on the FDA's approval system or by invoking this zombie law, the goal is to ban abortion outright.
Great. Well, I want to thank you all so much for sharing your expertise with us. I think you've highlighted for us the threat not only to different prescription drugs, but the threat overall to public health and health care of this case. And we really appreciate you sharing your time with us. Leslie, I'm going to hand it over to you.
We're going to let everybody go. We appreciate folks sticking through this. It's a lot of important issues, great panels. I want to thank everybody at Protect Our Care who did all this work to put this together. Andrea Harrison particularly, who led the effort, as well as the whole crew in the back. We will put a recording of this up on our website. We'll email it to everybody who was here and everybody who's been trying to listen virtually. We have a bunch of updated fact sheets so people know the dates and related information, so we'll try and make the job easy. If you have any questions, just reply back to Protect Our Care, and we'll try and answer them. I also want to thank some of our legal advisors who have made our work, particularly strong and who've helped Protect Our Care. That's Mr. Pincus Esquire and Zach and others here who have made their time available to us to be sure that we get things right when we try and educate people. And I want to thank the former Solicitor General for making the case for public discourse on these issues and the importance of educating the American public and the justices and the judges about what's at stake, which is the work that everybody in this room does. So don't let anybody tell you that these things are not affected by the outside world, because they very much are, and we appreciate all the hard work that everybody does in their day jobs when we don't eat up their mornings to save health care for the American people, because the threats out there are big, looming, large, and in many ways only getting worse. Thank you very much.
Thank you so much.